it's gone through and consulted its staff and it's at the next level, so we get an update as to understanding of the new landscape. So what I'm going to do is I've got 2 or 3 people to speak on the community mental health item. So what I'm going to do is I'm going to go to a presentation, open it up for a few questions, go to the next presentation, a few questions, next presentation, a few questions, and then open it up for a wider debate, just to make it a little bit more iterative. So members, if you don't get a chance to ask your question right at that start, just hold it in, because there will be time a bit later on. So with that, I'll introduce the presenters as we go. The first presentation is to give us an overview. So welcome to Jennifer Milmore, from a public health specialist from the Council Public Health team. And she is going to be joined by Jed Francique from Elft, who's the Borough Director for City and Hackney. Welcome, Jed. And also the Clinical Director of Elft from City and Hackney, Dr. Oliver Andlauer. And if I ask you to give your presentation first, I think it's going to be the case that, Jennifer, you're going to give a brief introduction, and then Jed's going to fill us in with a bit more detail. And then I'll go to Perpetua from the Transformation Programme after that. But to start with then, if I can go to Jennifer, please.
Thank you. Good evening, everyone. Just wanted to set out the stall in terms of the ground we're going to cover this evening, even though you've done it already, Chair, but just to be clear in terms of this being part 1, first of all. And so in terms of the ground that's going to be covered this evening, there's something about just being clear about what mental health means, so defining it. Talking about the prevalence of mental ill health and its determinants, and also looking at the mental health treatment system, so it's clear in terms of the context within which community mental health sits. We then will go into some detail in terms of the ELFT arrangements, the current arrangements, and also the drivers for change, who uses our services, the current model features, and then Perpetua will talk about the integrated commissioning. So this is part 1. In part 2, as the Chair's already identified, in January, we will then get into the detail of the new model.
Thanks, Jed. So yep, I'm Jenny Milmore. I work in City and Hackney Public Health, and I'm just going to be doing a bit of an overview of what mental health is and a little bit around how it's impacting us in Hackney. So first of all, I think just to start with a definition of health more generally, which is defined by the WHO as a state of complete physical, mental and social well-being, and not just an absence of disease and infirmity. And I think for mental health, there's 2 important things in here. One is that mental health is just part of health. There's sometimes a lot of stigma around mental health, a lot of misconceptions. It's part of health just as much as any physical health issue is. And then also that it's not just the absence of a condition. So sometimes people think of mental health very much in terms of mental health conditions, but actually it's a whole spectrum. And I think that's really nicely picked up by, again, the mental health definition by the WHO, which is a state of well-being in which an individual realizes their own abilities, can cope with normal stresses of life, can work productively, and is able to make a contribution to their own community. So again, it's a lot more than a mental health condition, and I've tried to illustrate that a bit on the right. So it's a bit of a spectrum. So good mental health might look like being productive at work, having good relationships, having a sense of purpose. Poor mental health might be something where maybe you experience stress or loneliness, maybe low mood, bereavement perhaps. Sometimes there's mental health conditions, common mental health conditions such as anxiety or depression, perhaps severe mental health conditions, more unusual, like schizophrenia or bipolar disorder. And you know, some people unfortunately do go into mental health crisis. Just a note on this, I wouldn't ever say anyone sits anywhere on this spectrum. Some people might have a mental health condition, but actually have good mental health. Some people might have relatively good mental health, but go through periods of worse mental health. So you may be at multiple places on the spectrum for any one person, but the key point is everyone has it, and there's a wide range of things. So very quickly, I won't go into much data, but around the national picture, 1 in 4 people experience a mental health problem each year in England. And so again, it's very normal. Think how many people are in this room, in your family, who you work with. It's very common for people to be struggling with mental health problems. It's not anything to be ashamed of. And again, we have all this stigma, but it's very normal. Severe mental health illness, which is what some people think mental health is all about, is actually only about 1% of the national population. And then I think very quickly, because it's relevant to discussions, but 28% of the total burden of disease is estimated to be attributable to mental health, but it's only 13% of NHS funding. So if it feels a bit like it doesn't get the same showing as physical health, that might be why. Also, just to really note that mental health can be a disability, which is a protected characteristic, and therefore we have legal requirements to make adjustments for people and make sure they're well looked after. So locally in Hackney, I've got here the diagnosed rates of depression and severe mental health on the right. So starting with depression, you can see from the graph on the left that it's really clear that rates have been increasing both nationally and across London and in Hackney. It's roughly doubled in the last decade. It's likely, and I should stress first of all, that this is diagnosed depression, so it's not necessarily the prevalence in the local population, but it's diagnosed rates. And so this might be influenced by factors such as increasing acceptability, increased awareness, both among health practitioners as well as the general public. So that might be at least some, if not all, of the increase, but it's quite possible there's also a genuine increase in prevalence. And the other thing to note from this graph is that Hackney is higher than the London average. So that's a bit concerning, although we are sort of similar in this trend to England, maybe slightly lower, it depends a little bit, but broadly similar, but higher than the average in London. For severe mental health, you can see with the top line, green line, about 50% higher than London and England averages in terms of rates of severe mental health, about 1.5% of our population. So that really is quite a concern. Again, these are diagnosed conditions, so true prevalence could be higher. And then I just want to talk a little about what impacts mental health. For example, again, a lot of people think about mental health as being what goes on in your mind, but actually there's loads of things that impact mental health, such as money, sleep, physical health, learning, education, physical activity, life events such as giving birth, losing someone, diet, having a job. Did I already say housing? I can't remember, sorry. Substance misuse, family relationships, and physical environment. And what's really important about a lot of these things is not only do they influence mental health, but they offer a huge amount of opportunity in terms of prevention. Like a lot of mental health prevention actually isn't mental health, it's these wider factors. And as a council, as a system, there's a lot of them we do a lot of really good work on and can influence. But the other thing that's really important to know is quite a lot of these can be negatively reinforcing. So for example, money, someone who has a shortage of finances and is struggling with money, they are much more likely to have a mental health problem, and it could exacerbate any existing mental health problem. Equally, someone who has a mental health problem, it's likely to, they're likely to have more difficulty managing money. There's quite a lot of evidence to show that people who struggle with mental health don't manage their money very well. At least they're more likely to impulse spend, find it more difficult, and so it negatively reinforces and becomes worse and worse. And if you've got a few of these factors, that can really create quite a difficult situation. And sometimes what we refer to as complex mental health need, where people have mental health needs, but also it interacts inextricably with some of these other factors, and therefore addressing that mental health need often requires a much more whole person approach than just mental health.
Fine, okay. Oh, with the background noise as well. I think maybe if we can, I think the only suggestion I can realistically make then is maybe we just slow down slightly. I don't think, I'm not quite sure we could try close curtains, I'm not sure.
Increase the volume a bit.
I almost think that the volume is actually making it slightly worse. I think if we just slow down slightly, and Jennifer, just to give you a steer, just because I want to make sure we have time to ask questions and for the other individuals as well. I think we've read the helpful pack, and we're sort of briefed with sort of the local supports, generally page 18 on our pack, but maybe just picking up on the diagram on page 19 as to how it all fits together locally. Okay, let's just do that, but I don't want to delay matters too much.
Next slide.
I think Cam, let's just leave it because otherwise we'll just. I'd leave it, Cam. Let's carry on, and we'll just have to do the best we can. So Jennifer, over to you, please.
Thanks. So I've got this one actually, but we are sort of co-presenting. Thank you, Olivier and Laura. So I guess it follows nicely with Jen's presentation on the continuum, I guess. So where and that's obviously not at all an exhaustive representation of what's on offer, but just to situate a little bit from self-care, people looking after themselves, reading books, looking after yourself, trying to improve lifestyles or by yourself if you want, is obviously a very, very important way to look after oneself, including after someone's mental health. And then there's primary care, which is absolutely central, with GP surgeries, but not only. Homerton providing talking therapy, so that's primary care talking therapy for common mental illness, so linking a bit with what was presented before. And then obviously the voluntary and community sector organization have also a very important role within that space, and further to also support people with mental health needs and common mental illness and sometimes more, as well as community pharmacy, for example, but many, many, many more. And then ELFT is in the area of secondary care, although we do have obviously a strong foot in primary care as well. At the interface, for example, all our community team are aligned with neighborhoods and with primary care networks, so that all the neighborhoods have one neighborhood mental health team with one consultant psychiatrist whose part of their role is also to develop those links and maintain those links with primary care. And so they go to primary care, they join multidisciplinary team meetings in primary care, in GP surgeries to support GPs and primary care professionals looking after people, sometimes with severe mental illness in primary care, as an example, as well as obviously all the services we provide in secondary care. And that's community mental health teams, specialist services for early intervention in psychosis, early detection of psychosis, rehabilitation, specialist psychotherapy service, and so on, some perinatal mental health. There's a range of services in the community in addition to, and that's the bulk of what we provide, alongside obviously crisis care. I mentioned a little bit about crisis, in A&E, in the community through the home treatment team, the crisis cafe and other offer for crisis care, as well as inpatient, so up on Homerton site in the East Wing, the City in Hackney Centre for Mental Health, where we look after people who need to be in hospital or there for mental illness. So that's the ground covered. And then there's highly specialist mental health units. There's tertiary care, which ELF does a tiny bit, but mostly would be highly specialist mental health, national psychosis unit, national autistic unit, which are in various places around the country. So that's the broad overview of where we sit, and then Jed's got a follow-up on LBH.
So the primary focus of this obviously is on community mental health services. What we wanted to do is provide a little bit of context in terms of ELF services. So as well as providing integrated community mental health services, which we provide in partnership with LBH, and there is a Section 75 partnership agreement. So there is integrated health and care services provided in the community through that partnership with LBH. So that's a very important part of it. But in addition to that, just for context, as Olivier has already highlighted, we provide mental health crisis and emergency care. We have a mental health inpatient unit with 115 beds and also specialist services. So that gives you the context of the services, and that equates to 700 people in the directorate and about £50 million worth of spend on mental health services. So to give you a sense of proportion, so a snapshot in October, the chart on the top left. So there were 4,000 plus people that we were engaged with in a snapshot at the end of October, just to give you a sense of scale in the community. In terms of crisis activity, there was between 500 and 600 people. So again, that's a sense of scale in terms of people in crisis, mental health crisis, and how many people we were working with, given that snapshot. And then again, in terms of inpatients, 108. Part of the reason for doing
can I
this.
just stop you there? So is this Hackney based or the whole of all of Elft?
Hackney.
And then the 4,200 in the community, does that include those under the Mind provision?
No, this is ELFT caseloads. When I say ELFT, this is the integrated offer ELFT and LBH. So that's 4,000. Yeah, so that gives a sense of scale in terms of what we're talking about. And part of the reason for this is obviously the importance of pivoting towards the community, because quite often when we talk about mental health, there's quite a big conversation about mental health hospitals and wards. But we just wanted to emphasize the fact that there are so many more people that we work with in the community. So the other charts give a sense of demographics. So in terms of age, you can get a sense of 18 to 24-year-olds, for example, who are particularly vulnerable, arguably. There's approximately 10% of our caseloads are people of 18 to 24 young adults. And in terms of older adults, again, roughly 10%. So that gives you a sense of the age groups that we're working with on our caseloads. In terms of looking at the community caseload by race, again, there's a sense, I suppose an important thing to acknowledge is 29% of the people haven't declared their ethnicity, so there's unknown. So that kind of skews the figures a little bit. But as an example, if we think about the population of City and Hackney, and roughly 21% being of African and Caribbean heritage, using that as an example, you can see in terms of the community caseloads, there's 27%. So that gives it, again, a sense of kind of who's on our caseload, who are we working with. In relation to gender, there's a 50-50 split, which is broadly what you'd expect. So that gives you a sense of kind of who we're working with.
So next, I won't go through all that slide, but it's the current model to access care, in part crisis, in part non-urgent care. And you can see that it's not as complicated and tortuous as it looks, but it is a little bit complicated. And so that's a lot of the feedback we've had from pretty much all our stakeholders, well, ourselves to start with, but also members of the public, users, as well as colleagues from voluntary sector, from primary care, and so on. So that's, if you go to the next slide, what we've heard when we ask for feedback about our services.
Can I just stop you there? Just so everyone's clear on this, we just go back to the previous slide. So we see that the bottom arrow, the talking therapies done via IAPT, which is commissioned by the Homerton, or Mind.
Yep.
Those are talking therapies. Is there any duplication of ELFT at the moment providing those similar sort of talking therapies, or is the provision that you're offering slightly different in that it's for a slightly more moderate need and a slightly more involved than a time-limited talking therapy offer? Can you just explain that current division?
Absolutely. So what, for example, what IAP, Homerton Talking Therapy is providing is what was in the primary care talking therapies that I presented before. So it would be in the vast majority for common mental illness, anxiety and depression, would be usually delivered by therapists offering 6 to 12 sessions. The offer we would have in certainly mental health care would be specialist for specialty therapies on a much longer time scale, talking a few months at the very least, 6-12 months of therapy, which would be for people with severe mental illness. So the trick is obviously not to overlap, but also not to create a gap between services. And that also is valid as well for the offer in the voluntary sector. So everybody knowing each other and kind of like trying to be as clear as possible who works with whom, without creating gaps, without creating too much overlap. Yeah, so to illustrate what I was saying again, I won't read all the comment, but basically people are saying it's too complicated. There are too many teams. It's hard to read. We don't really understand which even services of which team are under. And so there was really a sense that we needed to streamline a bit our services, which is one of the drivers that Jed will present now.
So taking all of that into account, there have been a number of drivers for change. So in terms of moving towards a new model, I mean, there are some national prescriptions in terms of what a good community mental health service looks like. Amongst other things, that includes it being a biopsychosocial model. Amongst other things, there's something about the model intentionally focusing on people with specific vulnerabilities, young adults, homeless people, people from racialized communities, as an example. So there's specific things that we're encouraged to respond to from good practice, but also national prescription in terms of community mental health. So that's one of the drivers. Also, because of the very strong, clear relationship we've got with LBH partners, there was something about us making sure that the health model dovetails with the social care model that's being developed and changed. So that was another key driver. As Olivier's already highlighted, something about the service user, the stakeholder, and staff feedback about kind of what's working, what's not working, and what we can change. Part of that, I think, as a bit of a risk for the whole system, is the capacity and demand challenges that we're facing. So that's, I think, part of the context as well. And financial sustainability. I mean, one of the things, obviously, that we need to pay attention to is the cost of our services and making sure we're delivering something that we can afford. So financial sustainability was inevitably another driver. But in terms of kind of really the final bit is that led us to set out a number of principles in terms of future arrangements, in terms of the kind of pillars of what the new model would look like. So there's something about us being really, really clear about what the ELF offer is and differentiating that from what happens in primary care and other agencies. So there's something about us being really clear about that. There's also something about us being really responsive to local needs and making sure that services are locally based and place-based and also embedded where at all possible within local communities. There's a big issue in terms of trusted assessments and people not having to tell their story more than once, and making sure that is owned and shared between different clinicians. So how we communicate and only enable people that need our support to only tell their story once was really important. Integrated working, that's with partners, but also within services was critical because, as you've heard, part of the feedback has been that actually solo working. Social care functions I've spoken about already. No wrong doors. There's something about if you need mental support, if it, either it's ELF or we direct you and support you to get support from elsewhere. We need to make sure we have efficient systems, etc. So that gives you a feel for some of the drivers, equity being another key part of it. And there's something about responsiveness to crisis, people that are in need, making sure that actually got systems and processes in place to respond in an appropriately timely way. So that gives you a sense of kind of what the principles have been in relation to the new kind of formation of the model, the new model.
Thanks, Jed. Petra, were you going to come on to the commissioning documents there?
Yes.
Just before we do, I just want to throw it open for some questions before we do that, just to make it a bit more iterative. Jed, just before I come to Councillor Turlett-Delov, we're obviously very familiar with seeing both on a council level or a health level transformation projects and financial sustainability being one of several factors. I understand there's been a significant uptick in demand that you have to deal with, and your budget may not have kept up with that. So I'm just trying to understand on the financial sustainability point, overall in this transformation program, is there going to be a reduction in spend, or is it more you're dealing with the same pot of money, more or less, but you're just trying to make it go further because of the increase in demand and your funding hasn't kept up for that? So can you maybe, which we of course understand, but I just want to sort of assuage any concerns that this may just be a dramatic cut to financing.
Yeah, so despite the financial climate, we are sticking to the same budget. So we are delivering, it's the latter point you made. We're trying to deliver more in a more efficient and effective way for the same resource. So that's the proposition.
I understand that. Councillor Totalov.
Thank you, Chair. Thank you very much for really helpful. Actually, my question goes a little related to what Chair just asked and what you responded in terms of efficiencies. I mean, it's really good news to hear this. We're moving towards that social, I think it's a psychological, community-informed model, which is really good. You probably know conversations we had about, the concerns that it goes back to the community. So my question is around whether this moment is also an opportunity to review talking therapies and the high dropout rates that there are. Especially because I can see you nodding because it's great news. Because we talked about this before, but it feels like, I mean, if there is no more funds and if we have a model that has a high level of, dropout rate, can we repurpose that so that we can bring back that to the community, especially given that we don't have extra funds? So yeah, I just want to see if there is that opportunity now for that to happen. Thank you.
So in terms of talking therapies, talking therapies, I'm not the best person to answer that, so I'm going to hand over to Perpetua, if that's okay.
Thank you. So firstly, in terms of the talking therapy services, it's absolutely an opportunity for us. This transformation work is an opportunity for us to look at how we can make sure that we are linking in with those talking therapy services, making sure that we're addressing any sort of fragmentation, looking at how talking therapy services are really responsive to our population needs. So part of the work that's happening around the transformation, we are really having discussions around how do we make sure that there is a link between the work that's happening in the adult community transformation pathways and the work that needs to happen around talking therapies. But the key thing is thinking about what our population needs, what have we been doing really well so far. So far, one of the areas that we're really strong in around delivering talking therapies in City and Hackney is having community-based, culturally responsive services that are delivered in partnership with VCSC sector. So looking at how we can build on that work, but also looking at some of the gaps. So what's our JSNA saying and how do we make sure that we are really aligned to and addressing those gaps? So yeah, so this is an opportunity for us to do that work. Yeah.
Just very briefly, I mean, that's really good to hear.
Mm-hmm.
Can I also make a suggestion around diversification? Because when you talk about, the voluntary sector and therapies, we have 35 models in the UK, and CBT is predominantly the one that we use, which is, it's a good system, but it doesn't work for all. So this is a great opportunity to diversify, which is something that the sector has asked for many years. It would be great if Hackney can lead on that. So yeah, thank you. That's really good to hear. But it would be good to hear about diversification, please. Thank you.
Thanks.
What I'll do is I'm going to take, I saw Councillor Adebayo first, and then can I ask, I'll use to hold your hand because I don't want to come to Petra's presentation. I'll come to you afterwards. So Councillor Adebayo.
Thank you so much for the presentation. And if you go to page 16, where we see the trend of level of depression going up in Hackney, I just wonder what we are doing, right, to respond to this upward trend of depression in Hackney, and what are the immediate steps that we need to take to reduce the burden on our local residents.
Thank you. So I think one thing to note is that we recently have been writing a joint strategic needs assessment, and that will be published in the coming months. And in that, there's quite extensive recommendations around what should be happening. And then the plan is then, I believe, to turn that into an action plan. So I don't know if it's fair to say more on that very shortly, but we're working really hard to look at all the challenges that have come up, look at all the data, and build on that to come up with a really robust action plan of what we're going to do locally.
And just to add, I think the key thing is understanding, what's driving, what's happening. So engaging with our communities and really having a clear understanding of, what are some of the things that maybe are happening that we need to be thinking about when we are shaping our services. So this is in relation to all of our pathways. So when we're looking at depression, as Jenny has just explained, so being really data-driven, thinking about what our communities are saying and engaging with them around how we're shaping our services, but also linking again with our pathways that are delivered through ELFT, linking in with our pathways delivered in primary care and in VCSC to look at what are the things that we need to be doing in terms of making sure that we have accessible pathways that deliver the right support at the right time as well.
Thank you. I've got Councillor Rathbone and Councillor Lucas to come after me. If I can now just keep things moving, Perpetua, to your report, which starts, members, at page 27 on commissioning. And Perpetua, you've already alluded to it, but clearly with the Wellbeing Network and the provision of their services coming to an end in 2027 and the 2,000 or so people, clients that they've seen every year, you've already alluded to it, but if you can just wrap into your presentation, is there any scope in this transformation to possibly pick up some of those service users from your perspective with what's going on here or not? Is that something directly the focus of this, or is that something for another piece of work? If you can maybe try and wrap that in to your presentation, that'd be helpful. Thank you.
I might need some assistance from my colleagues, but I will try. So I'm going to be talking, firstly, I'm just going to give a really brief overview of integrated commissioning in City and Hackney. So just to start off, my role, my title is Deputy Director for Integrated Mental Health, Learning Disabilities and Autism. I sit across ELFT, ICB, and the Borough, so LBH, and JED sometimes has referred to me as a triple agent. So I am all representing all three organizations. And before I start, I just wanted to also highlight that the ICB is currently going through a period of change. And so our current arrangements are evolving, structures aren't fixed, and things are very likely to be influenced by these wider changes. So in response to your question, I can only say that what we want to do in future is make sure that whatever the system, the changes that we make in City and Hackney will be influenced by those wider changes and what our structures look like. But there is an absolute commitment, and this is aligned with the 10-year plan priorities around looking at population health needs. So making sure that we are thinking of how we align wider strategic priorities with our local priorities. So I think the main focus is making sure that we are aligned to population health needs and our strategic priorities. So just going back to my information, I was hoping to be really, really concise. Yeah, so yes, I just mentioned that I won't be able to talk into lots of detail around the changes, but we do hope to provide further details once the system defines its future. And I've talked about my role and how it sits across the three partners. And I have been in post for just under a year, and it's a unique role, but what I can say is that it reflects City and Hackney's commitment to a whole system approach for improving mental health, learning disabilities and autism pathways and outcomes. So just staying on that slide, sorry, I'm just, so as integrated lead, I oversee all of the program of work around mental health, learning disabilities and autism. So in the commissioning, across the two partners, LBH and ICB. And I also sit on the ELFT, City and Hackney ELFT Directorate Management team. So I'm actively involved in provide operational leadership discussions and work. One of my reflections, just in terms of the length of time I've been here, is, as you can imagine, working across the three partners is a really complex role, and it's been particularly challenging during this time, given the financial constraints, the fact that the system is in flux, and so there is quite a lot of work to do, but then in relation to this context, given this context, partnership working is even more important. And for my role, this has meant looking at what mechanisms we have, both the existing mechanisms and emerging mechanisms to support and facilitate the integrated working.
Petra, just to explain to us, is this review happening in all other 8 boroughs in North East London as well, but you're focusing on the Hackney one? And is there going to be sort of 8 bespoke models, or are you going to have one model that's then rolled out for all 8? What?
So the changes that I referred to are ICB, so the nationwide ICB changes. So NEL as well is as an ICB is needing to align and determine what those changes look like based on what the center is directing around those changes. So I am referring to the NEL-wide ICB changes. The other thing I just need to clarify is that I only work in City and Hackney, so I am a place-based commissioner. Okay, so I won't talk too much on this slide, but I was talking about the context of and partnership working and the need to use the existing mechanisms and think about some of the emerging mechanisms that support integrated working. So in terms of our commissioning arrangements at place, one of the key mechanisms we have for integrated working is the Mental Health Integration Committee, otherwise known as MIC. So when I say MIC, that's what I'm referring to. This is a non-statutory place-based partnership that's been established to bring together our NHS providers, the borough, VCSC, people with lived experience and carers, to jointly oversee how services are commissioned, delivered, and also to ensure that they're tailored to local needs. One of the things that I will say is that there's a lot of work that needs to be done to make sure that this MIC is fit for purpose and is doing what it is set up to do. We know that there's work that's needed to strengthen and clarify the governance around the MIC. We also know that we need to make sure that we are able to really bring in and amplify the voices of people with lived experience, the voices of carers and VCSCs as part of that MIC. So it's not where it needs to be in terms of supporting our integrated working in City and Hackney. And this is a key priority for us. And we are in the early stages of looking at what we need to do to strengthen these arrangements. And just the table below, I know that Jed spoke earlier about the sort of provider commissioning arrangements and the joint approach to how we commission services and deliver services, and that's just a reiteration of it. And so it describes those local commissioning arrangements around Section 75, the Section 75, and it shows that throughout our adult mental health services, adult learning disability services, and our CAM services, they are integrated services that are being delivered. And also just to add that our services are delivered alongside VCSC partners, and I mentioned earlier around culturally responsive community-centered services that are delivered in partnership with VCSC. And so we've really been able to have strong collaborative partnerships with our VCSC, and that's something that we are looking to sustain even with the changes in future arrangements. Moving on to the next slide. So again, I'm conscious of time, but on this slide, I just wanted to just share the current commissioning priorities that sit in our place-based integrated delivery plan. These are going through a review, and we need to make sure that they are aligned to our 10-year plan priorities, that they're informed by our local population needs of JSNA, and that they are shaped by our key partners, including our VCSC and people who use services. But I will just quickly summarize them. And so the focus is on neurodiversity pathways, and that's about reducing diagnostic waits, clarifying that post-diagnostic support, and also enhancing more needs-based approaches. Also focused on Section 117 aftercare, and that's aftercare for any individuals who have been sectioned under section 3 or above under the Mental Health Act. So people who are entitled to aftercare after discharge. And that's about optimizing our resources and making sure that people who are really our vulnerable residents have got good outcomes and good quality support. And there's also some priorities for children and young people, and that's about improving access, cutting waste and enhancing outcomes in mental health services. And we've just been hearing about the adult community mental health work that's happening to really improve access to early intervention, prevention of escalation, and reducing fragmentation. And we need to make sure that, as I described before, that it links in with our VC services delivered in our VCSE pathways, as well as our integrated neighborhood models. And then we've got some priorities around learning disabilities and autism pathways as well. And that's about improving pathways, both in patients and community access, and dementia and end-of-life pathways as well, so strengthening diagnosis and care pathways. And then finally, we have on our integrated delivery plan, we've highlighted the need to look at the governance, because we know that that's a really important priority. So that's about, again, as I described before, ensuring that we have a functioning MIC. So just on the final slide.
Hector, just because I've been reading through this next slide here, a lot of that just sort of goes into a little bit more detail of the slides you just gone through. So if it's okay, unless there's anything you particularly want to draw out,
yeah.
I just wanted to go to some of the members. Was there anything you want to draw out?
Just to draw out that this final slide is actually, it's a more mill-wide summary of future objectives. These are in the process of being refined, and they sort of set out what will eventually become the mill-wide commissioning intentions. So they'll sit in the wider framework of strategic planning for the mill-wide ICB, and they'll cover 5 years. And they do set out how ICB will deliver against the priorities set out in the 10-year plan. I won't read into them too much, talk too much in detail about them, because they are being refined centrally. But I just wanted to share those. Thank you.
Thank you. Just picking up to where we were, I saw Councillor Rathbone, then Councillor Lucas. Councillor Rathbone.
Chair, I still have to say I still can't. I'm not hearing half of what's being said.
Yeah, I don't think it's not our guests' fault. I think that I was finding it's something slightly with the microphone setup. So I think we're in the position where we're just going to have to do the best we can. And then
I know after nearly 10 years of campaigning, I have been saying about this chamber. They are going to change it in December, apparently. So hopefully, after that length of time, that's all you have to do in Hackney, campaign for 10 years and something happens. Sorry, Chair, I just wanted to ask a couple of questions. One was about a long way back in these two presentations. It's saying that 1 in 4 people experience a mental health problem of some kind. And I wondered exactly what that means. You know, it's an easy statistic, but is that when somebody presented, so it's, as it were, literally a recorded event, or is it that, you know, somehow we know from the way trends are happening within the community that's the figure? Or is that a likely figure, or is that an actually recorded figure? And then just looking on from that, in terms of the Afro-Caribbean community, and obviously it's been overrepresented, and it has been for at least 20 years. And in terms of, and before that, of course, but that, you know, in terms of being recorded, I wondered what the trajectory here is, and if the numbers aren't improving significantly, what is the latest thinking on what can be done, and what hasn't worked here? Thank you.
Thank you, and apologies for the sound. So the first figure, the 1 in 4, I believe that's based on survey data. So it's not official diagnosis, but it's based on sort of talking to people in the community and speaking to them about their mental health. And so it's not an official diagnosis, but it's sort of based on having sort of similar criteria to what might say be a common mental health illness, I believe, or obviously a serious severe mental illness. So it's survey data. So it's interesting because with diagnosis, it's always underrepresentation because not everyone goes to their GP, not everyone reports. So that's where the 1 in 4 figure comes from. I mean, in terms of the ACH population, I don't know if services want to speak to that specifically, but again, referring back to JSNA, which is, as I said, shortly to be published, promise that we soon. The data is quite interesting. There's overrepresentation in inpatient services, but not so much in our talking therapies, not in the wellbeing network, and I think a little underrepresentation in community services. So it's not a clear across the board picture. It's quite interesting, and again, diagnosis of severe mental health problems tend to be higher in these communities than the general population. But so what we don't know is whether that, again, is that based on true prevalence, or is there something going wrong in the diagnostic procedures. So yeah, it's quite a complicated one to unpick. I don't know if we have any great answers. I think Jed might want to comment.
So just a couple of points. I wanted to piggyback on that to answer, to pick up the question about the wellbeing network, just picking up the 1 in 4 prevalence point, but also picking up the wellbeing network point, and then talk a little bit about the African Caribbean, people of African and Caribbean heritage. So just picking up the 1 in 4 point, and Jenny's answered it, but I think one of the things in terms of the context is post-COVID, what this translates into is probably approximately 20% more need or demand than capacity in the system. So that's, I think, a really important point, in that the system's under a lot of pressure. What that translates into, which is one of the questions about the wellbeing network, if the funding is not there, is the community services, ELF community services, LBH, integrated community services, I would suggest wouldn't have capacity to just pick up new demand, because at the moment, of all the referrals made to secondary care services, probably 70% are not deemed to be appropriate for secondary care services to pick up. So there's already quite a significant amount of people who need to get support elsewhere in terms of people that are referred. When you add more demand into that, it's very unlikely that people will get picked up. So I think there is something about a system conversation about how the system's overheated and how we meet demand in an appropriate way. So specifically thinking about people of African and Caribbean heritage, and you could argue this is a session in its own right that is needed. But as you've rightly pointed out, there's an overrepresentation in different parts of the system, including inpatients. But I think, and there's a range of issues: stigma, trust in the system, people's experience, etc. So there's overrepresentation in our inpatient services. There's particular overrepresentation of people in crisis, and police and other services being involved in the mental health system and conveying people to mental health care. So, but there's a range of issues that need exploration, including what happens when you're in a mental health system, your experiences of care, your access to care, and the outcomes you get as a result. So, but it's quite a big, thorny issue. But in terms of what we're trying to do in the community, is one, recognize that people need support earlier on and trying to identify that need, making sure, excuse my language, there are more culturally appropriate or culturally intelligent services or responses to that need, so that, again, people, to hopefully ensure that people are more likely to engage. I think another thing that's quite important is the relationship ELF and LBH have with voluntary and community sector services, people who've got expertise and relatability in this area. So there's a range of different things that need to be done, but I suppose the thing that I want to emphasize is, as part of the transformation, we are trying to address health inequalities, and there are inequalities in relation to people of African and Caribbean heritage that we definitely need to lean into.
Thank you, Jed. Pam? I'm going to go Councillor Lucas, then I want to go to Vanessa, and then I'll come to Councillor Adams after that. So Councillor Lucas.
Yeah, thank you, Chair, and thank you for your presentation tonight. It's a really important topic, and just sort of casting back to the first half of the presentation where we talked about some of that quite stark feedback from service users around the complexities of the system. Really welcome any steps to address that. Obviously, these are some of our most vulnerable residents, and the last thing they want at a moment of quite acute crisis for a lot of them is that complexity. So really welcome that. I think, Petra, you've given a really good overview of kind of what a place-based integrated commissioning framework looks like. But you mentioned in your remarks, obviously, the great unknown around the reforms that are going on in the broader system. So what is your sense of where place sits within that, and how confident are you that will continue, and will there be a diminished role for that? And just finally, if I may, on obviously these headline goals, the first column talks about improved inpatient experience that's close to home, but how will that work in practice on a NEL basis when we know a lot of them are sort of specialist sites? So just a bit of colour around that would be very interesting to hear more. But thank you again, it's a really important topic and great work being done as always. Thanks.
Thank you. Those are, for me, really hard questions. So what will place look like is a question that's yet to be determined and answered. And these are the changes, and these are the decisions that are needing to be made above my head. I am conscious some of my seniors are on the call and might be able to give a bit more detail around that. But in terms of, you know, what would place look like and how do I envision it? I think there's lots of really the importance, one of the most important things that we need to maintain and sustain in City and Hackney and at place is the connections that we have with our communities. And whatever place looks like in future, I think it needs to be very much hinged on that community integration, community working, and also looking at how we can build on sort of the neighborhoods. You know, what do neighborhoods mean, and where does VCSE sit in that? So how I would like to do it, if I was doing you know, the sort of the work around what the future looks like, I would be absolutely looking at, you know, what are the good things that we are already doing in City and Hackney at place, and that's really about how we work with our communities and our people who use services.
And about the inpatient part, maybe, yeah. Well, I speak under your control of that job, but it's a nailed-wide strategic vision, and so it refers to inpatient care closer to home. My understanding of that is it refers to the use of private beds, i.e., if an inpatient unit, a hospital, doesn't have any beds available, then people might be sent somewhere else, which won't be local by definition because the local beds will be full, and that has happened a lot in the past and still happens in parts of NEL. Fortunately, it doesn't happen anymore in City and Hackney. We used to have quite a few people being sent, and at that point, when someone gets sent, they get sent quite far away from home. It can be Birmingham, Manchester, wherever there's a bed. Obviously, it's not good for anyone. Being far from your usual support network, from potentially your family or your carers, the community team that knows you, all those aspects were obviously far from ideal. So in the past year and a half now, we haven't had any patients sent out of rehab beds, as they're out there called, in City and Hackney, and that's, you know, a lot of work has been done in the system with all our partners to really try preventing that, and we've been successful so far in preventing that. But I know in NEL that's not something that is necessarily always the case.
Thanks, Olivier. You've articulated it very well. I was just going to talk about right care, you know, right place, right time for mental health crisis, but you've articulated that very well. Thank you.
And Vanessa, I know you want to come in now as well, but I'll use this as an opportunity as well, just to introduce your presentation as well as sort of wrapping up to that. So you've obviously led the wellbeing network on behalf of mine that's commissioned culturally sensitive services for about 8 or so organisations over the last number of years. You say in your presentation that's some 2,000 users every year. There's been a significant budget reduction to your services, and your service is due to come to an end in 2027. Just to sort of give some further background, I mean, I think I recall about 10, 11 years ago, there being a end of a similar degree of these culturally sensitive services. I think at that time it was being funded by the NHS, and the council then sort of picked up the responsibility of doing it. But the background very much was then from GPs at the time, well, who are we going to refer to without these, just to try and make people realise that there was a lot of call from the GPs in the borough that culturally sensitive services was very valuable, and otherwise there was no one to refer to. So, and I know you're going to give us your general observations and thoughts, but who is this cohort going to be assisted by? Would be one of my questions to you. So over to you.
Yes, thank you very much. And I think the first thing I want to say, well, it's fantastic to be working on these problems collectively, and I think that enduring commitment to doing so is really valuable. But a mental health system that doesn't address the drivers of poor mental health is never going to be able to keep up with demand, particularly as those drivers are intensifying. And one of those drivers we have locally has always been about poverty. It's been about the effects of difference in poverty. And stigma, particularly around particular communities, racially minoritized communities, is really important. If you see your family member going to Manchester to have their inpatient needs met, it's not going to encourage you to come forward to have your own mental health needs met. And in terms of prevalence, what we see is that actually women from African Caribbean heritage communities have about double the rates of depression of the rest of the community. And what we do within the voluntary sector is often we work for years with families or networks of individuals to gradually come to the point where every single member of that family can have some of those underlying needs met, the relational needs met, but also then to eventually attend to their mental health needs. The other thing I really want to emphasize in the way that the Wellbeing Network and the wider BCS community has responded to the very significant mental health challenges in Hackney has always been really ingenious. You'll see from the paper that Larissa, my colleague, wrote that actually what we do as a local system is really innovate. We take what little resources we have through our community and rooted insights, and we find solutions that will work within that context. I also want to emphasize that the Wellbeing Network, as it exists, whilst we are funded by public health and have always been very well supported by the council, we also individually bring in over £1.5 million into the local economy to address mental health needs outside of statutory funding. So we've got a wide ecosystem of partners who've been working and collaborating really closely together and innovating together over many years in partnership with ELFT, where the reductions of funding actually will have significant ripple effects on our collective community capacity individually. So it's not just about statutory funding. The other thing I wanted to highlight, and this speaks to Councillor Claudia's point, in terms of talking therapies, and the kind of broader community provision, there's actually been a cut of around £2 million over the last year and a half, because we've got the Tavistock Primary Care consultancy service, but also the reduction of the Wellbeing Network that have taken place at the same time. And the cohort that they've really been working with is kind of people through their life course who might have quite complex personal circumstances which manifest as mental health needs through time, but aren't necessarily what would be defined as severe enduring mental health needs in that kind of diagnostic measure, but are indeed those kind of family mental health needs where you may have one family member who has a severe and enduring mental health need, who might be in and out of hospital, but then you've got a whole range of family members who are just about holding on. Now, the Wellbeing Network has always delivered psychological therapies, both as an IAP provider, so the NHS provided therapies, and you're exactly right. That is a very cookie-cutter approach, and whilst it will work for some people some of the time, the fact is that over 15 years of IAP, it cycles. It works for about 50% of people, about 50% of the time. So it works for about 25% of the people. Where we've had that support and resource through the public health funding is we've been able to deliver culturally sensitive services that work over much more flexible time. So we can work with people maybe for 6 months at a time. We can work with groups together. So we're both building their self-efficacy and therapeutically responding to their needs. One of the things we really wanted to emphasize that as a system, we need to think about data really carefully. So we need to think about population health needs across the life cycles rather than just around diagnosis. Because we're thinking about just sort of slices of people's lives, then we're losing all of those things that are the underlying drivers to mental health. Now, the Wellbeing Network works with about 2,000 people a year as a service at the moment, but we also have about 700 people that we work with each year, where we're able to provide open access. So we're able, within the neighbourhoods as they currently exist, which of course are going to be a key plank of how the NHS delivers sustainability, we're able to provide drop-ins. We're able to provide welfare rights and advice. And I think that we really need to emphasise that actually income is going to be an even larger driver of mental health crisis over the coming years, particularly as the welfare reforms start to take place and the economy worsens both locally and nationally. So we really encourage kind of collective thinking about population health together, protecting what works. And I think this is the challenge with the reductions and ending of funding to the Wellbeing Network, is that we have something that we've painstakingly worked together to innovate collectively, based on the community coming up with their own solutions. And so we really need to think about what that means about insight, the kind of information that we've been able to work with the data sets with the public health team to really understand what people need and how well it works, and to tailor the interventions. So if it's not working so well for a particular group, understanding, digging within that, what might support improve health for a particular group might not be for another. The flexibility that we have as a system, which is a flexibility we've never really had through IAP funding, is that we can then develop and tailor services, which then, as you can see from our paper, is getting fantastic outcomes as a local system. I think the rest of the country looks to see what we have locally within City and Hackney as the ecosystem as it stands at the moment, and thinks, actually, in spite of the level of need and the enduring and increasing need, actually you've got a system that is able to respond to that need flexibly. So you'll see within our paper, we're really urging thinking about the kind of mechanisms of governance and decision-making, the kinds of data and system insights that we need to have in order to allocate resource as carefully as we possibly can. I think also just want to recognise that when we take decisions, we need to make sure that we are thinking about a single point of access. And ELF has kind of gradually refined that single point of access, and we've had conversations as a local system for many years. But it's really important that when people reach out for help, that they have something that feels really immediate and tangible for them. And you will see in our paper that we've emphasised the role of potentially of Mind Forward, which is a one-at-a-time therapy model that we've developed that cuts waiting lists down to 2 weeks. We've been able to do that successfully and pilot that successfully through the Wellbeing Network aliside Professor Wendy Dryden, who is a Hackney boy, who is a very well-known, internationally renowned psychotherapist. So we kind of need to think less about services, but more around the intelligence and the resources that we have as a local system, both as a statutory system, but also local community organisations and just community members, so that we can make sure that those resources are allocated as effectively as possible. And the kind of signals that we give out about how we support people in a preventative way are aided the signals that we give out to people who are in crisis, because those people in crisis are not individuals, they are family members, they are the neighbours of other people who we need to encourage to reach out to help earlier, so we prevent people from getting into crisis. I think I just also want to reiterate that we are an ingenious collective community here. And so it's so important we think just about more than just optimising the services that we have available, and thinking about collectively how we ensure that we're coming up with solutions together. So that's not just about kind of what the NHS mandates us to deliver, it's about going back to the drawing board and saying, okay, as a community, what can we do together?
Thanks, Vanessa. We've got limited time, so I don't want to divert too much of it onto the microphone debate. I saw Councillor Adams, and then I saw Councillor Lynch. Councillor Adams.
Thank you, Chair. I've got a couple of questions. The first one is that I was just wondering whether they can just talk more about what governance mechanisms are in place to ensure effective oversight of Section 117 aftercare. That's the first one. And the second one is on the pre-diagnostic support. So how will comprehensive pre-diagnostic support be provided to individuals and their family while they are waiting for assessment, including access to information, care support, and early interventions?
I'm not sure, Petra, are you best to do that?
Okay, so just in terms of the question around Section 117 and the governance and oversight arrangements we currently have. So in City and Hackney, we have a panel, a multi-agency panel that meets to, where social workers refer recommendations for packages of care. I sit on that panel, and my social care leads also sit on that panel, and we make joint decisions around the appropriateness of the support. So that's at the level of the individual, one of the oversight arrangements that we have. So it's very much joint. And then in terms of one of the emerging things that we've been doing since I've been imposed is having a board, a Section 117 board, which really looks at the sort of more strategic elements around how we can really strengthen the working, how we can identify system areas that we need to be working on. So we have some real pressures both in the ICB and the LBH. We have some joint pressures around section pathways for people for aftercare support. So looking at, areas where we may have gaps around the need for high needs housing and what we need to be doing about that. So really what we have a panel that looks at individual support, and then we've also developed a board that has joint ownership of the register of people that are entitled to Section 117, and also looks at the strategic and system gaps that we need to be working on to be addressing that. And then your second question, sorry, I didn't quite catch it.
Pre-diagnosis support.
Is this
Yep.
in relation to
Yeah,
ADHD?
pre-diagnosis. Yeah, there's we also the concept of waiting well. So obviously nobody wants to be on a waiting list, but when that does happen, I'm thinking first of all, one of the priorities, which is improving access for diagnosis for neurodiverse, and in particular, in City and Hackney, would be for autism or ADHD assessment. Then the offer there, we're reviewing at NEL level to pull resources, but two, there's also resource pack. So we think about self-help, resource pack, elements of psychoeducation, what people can do as well themselves whilst they're waiting for a potential diagnosis, obviously if they are diagnosed, but so that people know what are the support groups that exist online or in person, what are the things they can do themselves in their life, if they struggle with attention, if they struggle with social interaction. So all those elements also communicate to everyone who's on waiting list for an assessment in the neurodiversity pathway, for example.
Thank you. Councillor Lynch?
Thank you, Chair. So we have before Vanessa, I think when I did a previous role as both me and Claudia did it as Borough Champions for Mental Health. So we do recognise the good work that you've been doing. So I think my question is, having listened to Jed and the ELF representatives, is, and I mean this with the greatest respect, has it been that we had to commission Mind because there was this gap in the services from ELF, and that what we've heard tonight is that the potential ambition with the transformation, particularly at place, would mean that those issues around equity of access and, the other things around, having a place-based commissioning, which basically is like, as you use the term, culture appropriate, is that is that what the situation is here, is that we have got, the funding may have been done because obviously there's significant challenges around funding within public health and within the council. But actually, if you were to look at it in a sort of very basic level, if we've got an NHS provider, they should be expected to have been providing some of the services that you were doing anyway. So I just wanted to just pick up, because it says that you've treated 2,000 people between 2024 and 2025. And I think we've had some data from ELF this evening, which is like sort of 4,268. Is that for a month? That's a snapshot. So 2,000 is actually, it's not that many people. It's awful, because I know that is a lot of people and a lot of outcomes that you've done are really positive. But I just wanted to sort of throw that in there in terms of this context of this and the sort of context of how many people that you're actually looking after. And is it not that we, within this commission, is that we push further for you guys to be able to have a sort of potential, no longer have an add-on in terms of the mind, but actually that needs to be, that should have already been part of the services that we were having from ELF. I don't know if that's a fair point to make, but I don't know, you can come back on how you feel about that, Vanessa, but it's just being very sort of just looking at it from the point of view of like, actually, we've already got an NHS provider. It is a bit upsetting that we have an NHS provider that hasn't potentially been meeting those ambitions around equity of access and culturally appropriate services. So anyway, I'll finish there, Chair.
Yeah, can I come to that first then? Yes, I mean, I think it's fair to say that mental health has always been a Cinderella service and has always been underfunded, and we don't see that changing. I think the last 5 years in the community mental health transformation did provide a considerable amount of additional funding, and we've been able to work with ELF within the community mental transformation within that as well, particularly through the mental health investment standard. But it has always been the case that local community groups have had to campaign for better mental health services, and most of us within the local voluntary sector are service user-led organisations. I think it is particularly important that the NHS is accountable about equity, but also, and of course I'm completely biased on this, but I think it is never the case that the NHS is always going to be in the best position to address those issues of equity. So I think that always needs to be that partnership. And that's partly because of the nature of NHS services being quite more medically dominated, and that isn't always what people need. Frankly, ELF in particular recognised the need for biopsychosocial approaches. Diagnostic approaches don't always work. We work in a transdiagnostic way. I think we welcome the move towards ELF doing more community provision and working collectively with us, but I think there's always going to need to be that community infrastructure, both to innovate, to hear voices, to connect people to each other through peer and mutual support. Because I think without that, the NHS, because its commissioning structures being very top down, it always means that move to flex and to be able to create together is going to be limited.
Yeah, I'm going to come briefly to Councillor Adebayo and Councillor Turber-Delol. I'm not going to, this discussion, I think we've obviously returning to this in January, and I know that's primarily going to be for the ELF transformation programme, but I think just to give heads up, I mean, I would like to revisit this issue, because we've got Jed understandably possibly saying that possibly not being able to have the finances to backfill everything from the wellbeing network. There's obviously, and Councillor Lynch has really hit upon the point about a funding issue as to who funds this service. So I don't know, it just may be that just to maybe Dr. Husbands, and I know Kirsten's on the call as well, from a doctor's perspective, is there a need, are we leaving a gap here if this service is completely decommissioned? Dr. Husbands, what conversations have been had from NHS colleagues about backfilling if it is needed, this need? I don't want to, I think that's a conversation. I think can we maybe just, because I know Vanessa, you're going to join us again in January, but that's something I can maybe pick up in more detail there. But I just sort of give heads up now. That's something I possibly just want to explore in a little bit more detail. For the present purposes, just to bring this to a close, because we're nearly at time. Second question, I'll take them as all together. So Councillor Turber-Delol, Councillor Adebayo, Councillor Adams, just very quickly, please, and I'll take all three together, then go to answers, then close the item.
Thank you, Chair. Thank you for the report. I just wanted to say that it's very important the distinction you made about CBT, talking therapies and CBT, because there will be people listening, and it's really important to say that it is a system that works. It doesn't work for everyone, but I guess this is where it goes with data as to what is it working, what is not for residents. So then we know why we have these dropout rates and how we can repurpose. So I thought it was really important that we clarify that actually it's not an anti-CBT and not anti-talking therapies, it's just it doesn't work for everyone. I do want to say that Hackney does have an ample offer, and I think, I've said that very openly when I was the mental health champion, that I was shocked, and I can see you nodding, because Hackney does offer that. I've been a therapist for 15 years, and really Hackney does offer a lot. The issue is awareness often. We don't know where those services are, and that is perhaps the work that we need to work on as well. I just wanted to check in terms of community work, just as a brief question. Are we looking at models where community mental health has worked in other areas of the country? I know in South London, I can't remember exactly the borough, but we heard in one of the commissions for the mayor of London at the time when I was mental health champion, but I can look for the name and send it over. But are we looking at models of where it works so then we can also apply that here? Thank you so much.
Councillor Adebayo?
Thank you. My question is about the waiting list. We know that when people are waiting too long, tendency of them dropping off is high. What is the current waiting list for IAP in Hackney?
And Councillor Adams?
Thank you, Chair. My question is very simple. I was just wondering whether there's any immediate steps that can be taken to reduce the 18 months wait time for LFT, secondary cares, psychological therapies.
The last two questions there on IAP wait lists and the 18-month wait list. Jed, I'm looking at you. Are you okay to? And then obviously Councillor Turpin-Love's point about looking at other areas.
Yes, so we have looked at other areas. It's been quite an important thing in terms of making sure we're learning from good practice elsewhere. So we have not just looked at London, but elsewhere. So that's been a very important part of it. And I think when we bring the model back in January, what we can probably do is give some insights into kind of the good practice, how we believe it aligns with good practice. So that's definitely the case. I was going to jump to the last one as well. In relation to weights, generally, there are a number of different waiting standards. The wait for the first appointment that's been brought in nationally is 28 days. The current figure in terms of people on TPA who are waiting for their first appointment is 77% of people on health books are actually seen within 28 days. There are long waits in other aspects, longer waits in other aspects of the service. So if you're waiting for, sometimes if you're waiting for psychotherapy, if you're waiting for neighbourhood psychology, there will be waits, but 18-month wait is generally a figure that I don't recognise, to be honest. But what we can do is circulate the waits for our services. Just so you know, the final thing to throw in, we've currently got a number of people on waiting lists, and we're touch wood, going to be doing a waiting list initiative, which, subject to it being funded, will reduce all of those waits to zero by March, subject to that getting funded. We've got a business case in a minute. So waits is something we're very, very cognizant of, and it's something that we, myself and Olivier, and prepared to look at on a weekly basis, pretty much.
Do you know the IAP waitlist position, or? We do.
I know what it was for when we got the DSNA data. So it was actually only a couple of weeks for an average out appointment, but there is variation within the service. So for people within IAP, there's different pathways, and for the more specialist pathways, some people are waiting longer. It is one of the recommendations to try and understand more actually where the issues with waiting lists are, and to look into that further.
Thank you. I'm at time, Councillor Adams.
That question has not been answered. The waiting time for the 18 months, what can be done to reduce it?
Well, I think Jed indicated there's something they're very conscious of. Have you?
Yeah, so for the audience of that, the figure 18-month waits isn't one that I recognised, and I talked about the wait of first appointment of 28 days and the percentage of people on CPA 77% seen within 28 days. I would say that there are some longer waits, and obviously that in some aspects of the service, especially psychotherapy and neighbourhood psychology, etc. But generally, people shouldn't be waiting 18 months for therapy. That's not something I recognise. But what I will do as a commitment is circulate our waiting list figures so you can see what they are. And also what I'll do is, like I said, we've got a waiting list initiative that's on the stocks, and hopefully we'll get funded, and that will reduce the people waiting for first appointments and those that have been seen for 6 months. Once they're in treatment, that aims to reduce all of those waits to 0 by the end of March. But I can circulate the waiting list data.
Okay. Thank you, Jed. What I'm going to do, because we're at time, I'm going to draw that item to a close, but knowing for well, we've got it back in January, where hopefully we'll have a better microphone set up. Yes, I thank you very much. We're obviously going to get more detailed information as to the transformation, I hope. There was at one point there a slight fear with all the personnel changes at in-L level, whether that could end up being delayed, but let's see where we're at with that. And then then also the question in terms of the commissioning for the wellbeing network. Councillor Lynch?
No, I just thought it would be wrong not to mention the news that came out that there has been some green lights around the redundancies and things that will probably may affect our colleagues at now. So I thought it would be pertinent for us as a committee to, we are recognising of those challenges you've got, and hope that the news today will have some impact in terms of staff feelings and the sort of long time that they've had, really. So I hope none of you are actually going to go, but just thought it would be worth mentioning that, because that must be an impact, I'm sure, tomorrow when people are at work and across the system, not just in the city in Hackney, but across NEL as well.
Thank you, Councillor Lynch. Yes. So that's where we do, and then we'll obviously revisit this the concern I think this commission's long held in terms of that provision that the wellbeing network has provided. As well. So thank you very much, everyone, for your really helpful and insightful comments. I'm now going to move to the second substantive item on the agenda, which is the regular air quality report we get. I'd like to welcome the Cabinet member, Councillor Young, Dave Prue, who's the Land, Air and Water Manager for Hackney, Tom Richardson, the Environment Projects Officer, and Sam Kirk, who's the Assistant Director of Climate. I think everyone there is joining us online, so I'll now turn to my computer. Sarah, Councillor Young, did you want to give a brief overview, or are we going straight to the officers to do the introduction?
We're going straight to the officers, but please feel free to come back to me for questions.
Will do. And officers, guys, I don't know who of you might be leading on this, but if we could maybe just have sort of 7 or so minutes in terms of presentation and then go to members, please.
Yep, thank you, Chair. That was exactly echoing what we were going to do, so you've introduced us well. Dave, have you got the slides, please? These are for the benefit of everyone attending. They were reproduced in the papers pack, so hopefully should not be too unfamiliar there.
Sorry, just bear with me. I am.
While we're waiting to be shown, I mean, I think most of us have got either on our computers or in hard copy. We'll be showing now.
Lovely. So thanks there, and thanks for the introduction. Dave, you can just carry on to the next slide straight away, please. So, of course, we've been here before the last few years to discuss air pollution, the effects of air pollution on health. The diagram just on the right giving an overview that is, I'm sure, familiar to everyone on this commission about the health effects and how they can affect everyone throughout the life course. What we're going to have a quick run through today is the air quality trends that we've seen in the last year, especially focusing on 2024, which is our last report. Period, the progress we've made on the current air quality action plan, and what we are doing on the new air quality action plan 26 to 2030, which is going through for adoption in the next few months. Thanks, Dave. Next, please. So I'll just go through pollutant by pollutant because I think this is relevant and of interest to the Commission. And we'll start with nitrogen dioxide. So that's typically from road traffic, but also combustion, heating systems, etc. What we saw in 2024 is that we saw a decrease at over 90% of sites. We've got 150 of them. So continuing the trend that we've seen over the last decade or so. What was interesting last year is we saw substantial decreases on red routes. In 2023, you may recall that we saw some quite interesting increases, but that trend doesn't seem to have carried through. So we've now got some decreases on red routes, particularly the A10. We do still have an exceedance of the nitrogen dioxide annual mean objective, only one out of those over 150 sites at Pembury Circus. And we do still have some areas of the borough where we're near that level. As I said, the A10, Stoke Newington High Street, Wick Road, for example. And our main challenge really is just to get those stubborn areas down. And I'll touch on that in a little bit later on. Next, please, Dave. So particulate matter, PM10, PM2.5, those particles in the air. Again, the trend is very similar to previous years. We're not seeing a substantial increase or decrease in PM10 or PM2.5, but some better news is that in 2024, our adopted PM10 target that was based on previous World Health Organization targets was met at all of our sites except for Homerton Library, and even that was just a small exceedance, 20.2 micrograms over a target of 20. And actually, where we monitored PM2.5, that was below the target in 2024. That was monitored at Old Street, 9 micrograms versus a target of 10. As I mentioned, the trends are less clear than NO2. And the real challenge we've got now is why there's been no change. There's changing sources. There's, for example, emissions that are not coming from car exhaust, but coming from non-exhaust traffic, wood burning, construction, etc. So we need to focus on those and drive those down. I'm going to touch on ozone, which we haven't covered in previous years and isn't really formally part of the framework we work under, but there is targets for that and there's objectives for that. And we have seen quite a substantial increase in average levels of ozone. So that graph is annual average since 2012. And in 2023 and 2024, we did exceed the 8-hour mean objective. So we need to have a look at how we can drive down ozone. The challenge being it's very complicated pollutant. There's no direct emissions in Hackney, and so much harder to control, especially at a council level. So we need to look at what we're doing there. Next, please, Dave. So some achievements over the last year or so. Some of these won't be new, but I'll start with expansion of the air quality monitoring network. As I said previously, we were only monitoring PM2.5 at one location, and we've tripled that. We've got 2 new monitors alongside some low-cost sensors to really understand what's happening with particulate matter and just improve the coverage of monitoring across the borough. The AeroAir project, which was funded by DEFRA, that's been going for a few years, and we had some real positive outcomes from that. And probably of interest to this commission was the quality pharmacy conversation project. That actually took place in Newham, but is of interest to the NHS, and we've been in contact with some working groups about the positive outcomes of that and how that can be expanded. The Zero Emissions Network, that's been going for a few years and has received funding from the Mayor of London relating to deliveries for businesses. So, for example, last year, 2024, we had 24 cargo bike grants and 5 cargo bike leasing businesses undertaking leasing, and more businesses signing up to that project. The Healthy Waterways project, so that's looking at air quality on our waterways, so emissions from the canal boats, understanding sort of barriers to those on the waterways to adopting cleaner technology, and looking at what we can do to encourage cleaner technologies there. A couple of transport projects. So as I mentioned, Pembury Circus and the NO2 exceedance. I'm sure everyone's aware of the Hackney Central Transformation Project and the work's being done there. Hopefully that reduction in traffic should really bite that exceedance end that and bring those concentrations down. We've had positive outcomes on new cycleways in Dalston and Leabridge Road, new cycle hangers. We've had over 500 in the recent tranche, the recent project. £400,000 on green screens for schools. So what was mentioned last year was areas where there is high levels of air pollution and people being exposed to that, and what we can immediately do there. And we've got around 15 that are in the pipeline almost to completion now. So hopefully that will have some positive impacts on those most vulnerable. Electric vehicle charging points as well. And just finally to touch on what is being done with Hackney Light and Power and our energy team, what they're doing in the decarbonisation, the Hackney Community Energy Fund, which to date over the last 4 or 5 years has dispersed almost £1 million to community groups to improve their heating technology and therefore reduce emissions there. So that's just a list of things, of updates since last year. Thanks, Dave. So as I mentioned at the start, we are going to a new air quality action plan now that our current action plan is up for renewal. And what would probably be of interest to this commission is what has changed, what is different. I would encourage those to review the themes and priorities that are in the paper pack. But in summary, we want to progress towards the WHO guidelines, the World Health Organization guidelines. And so we're aiming to commit to a 30 microgram per meters cubed annual average NO2 target, continuing the direction of travel where we're successful. So those actions we're taking that we've got positive outcomes, we have good things happening. Focus on the remaining NO2 hotspots as explained. But really what we need to do now is look at the less low-hanging fruit, for example. So with traffic, the NO2 is going down from the exhaust, but we've got non-exhaust emissions, tire and brake wear, heavier vehicles on our roads. We've still got an issue with idling, what we can do about that. The increasing proportion of emissions that aren't from traffic. So looking at construction sites, whether that be construction dust or machinery on construction sites, managing wood burning, which is increasing across London and across the country, really. Things like mobile generators, events, filming, how we can reduce the emissions from those sources. And what we can do about air quality on our waterways, as I mentioned earlier. We also do want more integration with public health. And as I said, we've had those conversations with our NHS partners about projects such as that which was carried out with AirAware, and really a bigger focus there. And while our influence might be limited, we want to introduce a focus on indoor air quality. So what we can do in the buildings that we manage or have responsibility over, or raising awareness for people in their homes. Thanks, Dave. Final slide. So hopefully that was quick enough for everybody. We are through about a year into the process for adopting our new air quality action plan. The statutory consultation went from July to 26th of September this year. What we're currently doing is analysing that, bringing the outcomes together, pulling those together into a final draft. It says here we're looking to submit to the Mayor of London at the end of November. What we really want to do is just get a second round of feedback from them. They did give some substantive comments during the consultation, and then to take that to Cabinet on the 26th of January, which following their approval, we can submit that for adoption formally and start work in earnest on all of those actions in there. So that's it from us, from the slides there. Hopefully we've got plenty of time for questions. I'm aware that was a lot of information all in one go. So yeah, Dave and I will be on hand for questions, as well as Councillor Young as our lead member. Thank you.
Thank you, Tom. Yes, there's a lot of questions here in the chamber. Yes, I mean, I echo the observation you made in terms of not just focusing on the lower hanging fruit, but going from some of the more challenging areas. Because clearly from a health perspective, it's the red routes, those areas curbside on those main trunk roads that clearly have the biggest health impact, and that should really very much be our focus on the action plan. So when one of the country's leading experts spoke to us a few years ago, we were asking, well, what can local authorities do? One of the things he was sort of saying in terms, say, for example, for schools, was thinking about HEPA filters and things like that. So, for example, where we are still exceeding NO2 on the national limits, in my ward by Pembury Circus, and you've got the primary school opposite Hackney Down Station, to what extent are we, because I think the Mayor of London actually announced some HEPA filters for some schools. I think he announced 200, I think I recall hearing at some point last year. To what extent are we thinking about such measures, such as that? And then my second question before I throw it open to other members was just in terms of clarity and consistency of the figures. Because for years we've sort of said, I think we've been sort of saying we're better than the WHO figures. Now we seem to be benchmarking in some ways to national figures, such as below the 40 figure. But then at another point in the plan, we're saying we want to go to 30, but that was a WHO target in 2021. So I mean, and I've had this report now for 3 or 4 years, and I'm not, just as a bit of feedback, I think there really needs to be complete consistency on figures and what we're going against and what's the national benchmark, what's the WHO benchmark, where are we, and that just needs to follow through all the time. Because if I'm not fully on top of understanding what it is, and I'm seeing this every year, there's no hope of that being communicated in a translatable way to the public for them to understand it. So if you can answer those, and then I'll come to members, please.
Yeah, thank you for those. So the red route and the trunk road situation, yeah, it's very difficult. I think one of the positives is that we did see a reduction pretty consistently in our monitoring sites there. So in our new plan, we will be advocating to TfL, for want of a better word, on action on the red routes. You know, TfL do have their own air quality plans and strategies, but yes, we will be trying to up all of the communications we've got with them, working with Street Scene and the transport team to get those concentrations down there. Things like any of the bus routes that may still not have electric buses on. I'm not actually sure exactly if that is the case anymore in Hackney, but you know, making sure that that's rolled out on all the routes. It's in the plan, and we know that that's important, and we're working with Street Scene on that. You're right, the schools filters program by the Mayor of London, it has now been announced. There are a number of schools in Hackney that have been nominated. I can't say the exact number off the top of my head. I think there is some work still being done on which ones will get the first tranche of filters. But again, the evidence is there to suggest that they are effective. So that program's being rolled out, and yeah, we'll look at the results of that and see what we can do after that. You mentioned something about Pembury Circus. Have I missed something there?
More about just the consistency of the figures, I think, was my...
Oh, yes. Yes, sorry, you said about your ward in Pembury Circus, but about the WHO figures, yes. Yeah, I appreciate that. That's a problem, especially when we had, in our last plan, the adoption of 2005 World Health Organization targets, and then the WHO released a new tranche, and then in that there's things like interim targets and that sort of thing. Hopefully we've clarified that in our new plan, but it unfortunately is not going to be any easier with all these numbers flying around and inconsistencies with the national regulations. But what we hopefully will be doing with this commitment to 30 micrograms for annual mean NO2 is we're saying this is lower than the UK objective, which we don't see changing anytime soon. This relates to one of the interim targets of the most recent WHO guidelines. We don't have to talk about the old ones there anymore. And that's what we will go to 2030 with the aim and the pathway for after 2030 to go down towards that guideline value, which is that ultimate goal, 10 micrograms per meters cubed, that nowhere in Hackney yet meets. But we hopefully we're choosing 30 micrograms per meters cubed as a target for the next 5 years with the aim to go further.
Thank you, Tom. You needn't answer this point, but just my bit of feedback then, seeing as it's still being worked on, is just a very simple table comparing the different national targets, the interim WHO target, any other interim ones, and where we currently at, so you can sort of scan across, would aid transparency, I think. So just the point of feedback. Now, I've got several hands here. including from Councillor Postle, who's chair of another one of our commissions, who's joined us. And I know Councillor Young. I saw Councillor Lynch first, and then I want to bring in Councillor Before, who hasn't asked a question yet, and then I'm going to double back to everyone else. So Councillor Lynch first.
Thank you, Chair. I just have a very concerned sort of lack of confidence in some of this. It builds on what you said around the clarity and the consistency of the data, because it's great that we've got lots of the monitors, but I think for us as a commission, it would be, for us, we want to see the meaningful outcomes of this. So how does this relate to potentially an example outcome would be that, we've got some very good population health data across the system, has all of this with these various interventions that have happened, haven't really made that much of a dent in air quality, but actually, has it actually been meaningful for our residents? Has it reduced the exacerbations of respiratory related conditions at the Homerton? Has it reduced, the prescribing of inhalers across Hackney? All of those key, meaningful, equitable, population data that will show that this has had any impact. And I think, you've mentioned Homerton Library. I had the most dreadful experience last week where I needed to take a relative to the Homerton, and the recent LTN that's affected Chatsworth Road and the surrounding areas. I find it incredible that, the idling that's been talked about. Why should my residents on Homerton High Street have consistent high rates of idling, and also those across, in other areas? Because I know, particularly in my ward, I've got a number of large social rented properties that are having to have an increase in car emissions and such like, whereas we know that there's other sort of, leafier areas of across Hackney that probably have people that have already got an advantage in terms of their health outcomes. But yeah, thank you, Chair.
Tom, did you briefly want to respond to that, and then I'll bring in Councillor Young at this point, and then come to Councillor Before.
Do you want me to answer on the LTNs? Because obviously that's not Tom's responsibility, but it is.
Okay, yeah, fine. Okay, thanks, Councillor Young. You go for that.
Thanks. Just to reassure, our low traffic neighbourhoods, and there's been quite a bit of research done on this, absolutely are not in the areas. In fact, there is a higher proportion of people who live in LTNs who are of lower, more socioeconomic disadvantage than those who are advantaged. So our LTNs are not providing more benefits for those in leafier, what we might call leafier, more wealthy areas than poorer areas. The opposite, in fact, is interestingly, I'm very happy to share with the Commission the research. Interestingly, the research shows the opposite. So that's one point on low traffic neighbourhoods. On Pembury Circus specifically,
can we just let Councillor Young finish? Okay.
On Pembury Circus specifically, the air quality data that you're seeing does not include the air quality data since Pembury Circus has changed, and therefore traffic isn't going down there. So I think we expect to see a very dramatic change in those measures once those changes bed in. So at the moment, obviously, we've got huge roadworks there, so nothing's going down that section of Amherst Road. But once the changes bed in properly, that will be the time, I think, for us to really look at the air quality monitors there. More broadly on low traffic neighbourhoods and sort of our transport strategy, I am very, very well aware, the street scene team are very well aware that we are pushing traffic from smaller roads onto main roads. That is one of the impacts of low traffic neighbourhoods. The overarching policy is aimed at reducing through traffic. So overall, you should get less traffic coming through Hackney that is neither coming to Hackney nor coming from Hackney. So you should see a reduction overall. And we are in the midst of developing a new transport strategy now. One of the absolute key focuses of that is main roads, not just how we get traffic moving on main roads, but how we reduce the traffic overall on the main roads. So I'm really conscious that that is something that we need to tackle, and that the air quality on the main roads is something that we need to tackle, and particularly that we don't want, as Councillor Lynch says, traffic idling, sitting idling on roads like Homerton High Street. and reducing the reducing air quality for people walking along the street. So just wanted to pop in on that. Happy to answer other questions.
Thanks, Councillor. I know Councillor Lynch wants to come back, but I haven't. Councillor before has not yet asked the question, and I've got sort of 12 minutes left. So I want to go round, make sure, and if there's time, I'll come back to Councillor Lynch for your follow-up. Councillor before.
Thank you very much, Chair. I think mine is around the EV charging points, and I've got about 3 questions. I think one is about the surcharge. It's too expensive to extend that, what they can do to address that. And secondly, how often does it get serviced in terms of making it available for users? Because if little problem like raining or something, the internet service doesn't work and it takes forever for it to get fixed. And I would like to know how often does it get serviced to make it available for service users, and what ways are they doing to improve to get it like the internet service stable in a long term.
Tom, are you best to deal with that, or is that an area for Dave?
I think for neither of us, Chair, there, obviously this is surrounding electric vehicle charging infrastructure, which will be for street scene transport colleagues. I'm sure we can get that question to them, but yeah, not for us, I'm afraid.
I've taken notes, so I will get that question over to street scene. It will be for them to provide a response on that.
So Councillor thought they'll pass that question over to street scene, who can provide an answer to that. Dave, while you've just got the microphone, you had your hand up. Do you want to make any observations on the comments that have been made so far?
Yeah, it was only a couple of points. I mean, Tom has answered the question, but in terms of the school filters programme, we've been having conversations with the GLA to identify the schools, and there were 7 schools identified in Hackney. So I do have a list that we're trying to put them in contact with those schools. I know they've been successful with 3 out of the 7, but it's an ongoing sort of project to try and get those links.
Guys, members, can we stop not talking, please, when members are speaking? So sorry, Dave.
Okay, and the second point was just in relation to the population data. I know that well, Tom mentioned about the pharmacy project that was carried out in Newham. So this was part of the DEFRA project that Hackney was part of, and there was 4 boroughs taking part, but each borough had sort of slightly different kind of aspects to it, and we learned from each other. So Newham had the pharmacy project, and there was a report that was released on Clean Air Day this year showing the findings. Essentially what it was is, if we provide training to the pharmacists so they can have good quality conversations with the people when they come in to get their medication, does improving that information to the patient about air quality translate into better health outcomes? And the report has been published, and it showed that it did. It had a marked effect. So,
Councillor Potter, you've joined us as Chair of Skills Economy and Growth, and you've got your hand up for a question. Do you want to ask that?
Apologies, Chair, I just pressed the wrong button. Okay. So my question was just to follow on the main roads theme very, very quickly. Appreciate the increase in monitoring. Both Councillor Hayhouse and I are aware that when we had the scrutiny review right at the start of this municipal year, we got quite a lot of feedback from residents in terms of concern about the main roads, as Councillor Young has emphasised, but about the air quality on those main roads. Does those monitoring stations mirror, the kind of concerns that residents had in particular in terms of the areas? Have we got sufficient to really measure and monitor where, we think the worst kind of air quality is? My other question is, in terms of boundary roads, and I can talk more specifically about my own area, are we putting leverage on local, our neighbouring boroughs, when it's our residents that are being directly impacted? I'm talking about places in my neck of the woods like Blackstock Road and 7 Sisters Road, where I know there is an air quality issue. Are we providing suitable, pressure? I know that we share kind of responsibilities for different roads in kind of different ways, but I just want to make sure that all our residents have got your oversight, you know, in terms of air quality.
Tom,
Do you want me to take that one, Tom?
Yes, the latter part of, the second question, probably best, Councillor.
So Councillor Young, if you do the latter part then, please.
Yeah, sure. The first thing to say is changes are being made, you know, by the Mayor of London, by our neighbouring boroughs, Islington, Tower Hamlets, Haringey, as well as by us. And we do, you know, we are notified of those, and our residents are involved in the consultations. And we do talk to our neighbouring boroughs a lot about local projects. In your specific area, Councillor Potter, as you know, we've been working with Haringey and Islington to talk to Transport for London about making improvements around Manor House and the roads that come down towards Blackstock Road, in order to make improvements to have an improved impact on Blackstock Road. So I suppose the answer is yes, we do work with our neighbouring boroughs, but we also, you know, some of that is also getting Transport for London to take more of an overview around an area, including those boundary, as in boundary of boroughs roads. The roads where our measures are not dramatically better than they were a few years back, so it is worth us sort of, you know, heaving a bit of a sigh of relief on how much better the air quality is. And that is not entirely down to Hackney. A great deal of that's down to the Mayor of London's ULEZ policies and other surrounding policies in terms of the types of vehicles, you know, and the fuel that they are using along those roads. That doesn't mean there isn't a great deal more to do. That absolutely is a great deal more to do. But we are, you know, the air quality is improving. There was something I wanted to come back to, actually, which was a point that, a very valid point that Councillor Lynch made, which is, do we know whether the impact of the improved air quality means that we're seeing, you know, fewer children with you know, advanced asthma or other air quality related conditions. Yes, there's research on this, but it is really quite difficult for us as a borough to know whether a particular change that we've put in on a particular street is impacting, you know, how it's impacting on the children who live on that street, for example. So that, you know, that would take many years to have the data on. And we also, you know, correlation and causation are big problems there. So I think the answer is we don't know on a kind of micro level. We can look on a macro level across London at rates of asthma, for example, but we can't say whether in Hackney at the moment the changes that we've made have made a difference to those children's health.
Thanks, Councillor Long. You're breaking up ever so slightly, so it may be just beneficial just to turn your camera off, just so we get your microphone. But just to go to Councillor Potter's nub of her question, are we satisfied we've got sufficient monitors on the trunk roads that people are most concerned about? Tom?
So firstly, I think there was also a point just about the data that's being shown, and as in the summary is that we aren't seeing with the pollutants relating to traffic substantial increases anywhere, including on the main roads, on the TfL roads. As I mentioned, we've got 7 automatic monitors in Hackney, most of which are on the A roads. We can't get them on the red routes because we don't own the land, but we've got them on the A roads, and those are you know, a substantial investment in good, high quality, frequent data that will show us peaks in traffic, changes throughout the day. We've got them on green lanes, you know, Dalston Lane, on Graham Road, which I appreciate is quite a concern among many residents, and Homerton Library next, you know, Homerton High Street. So we have the monitors there alongside our sort of passive monitors, which are monthly averages. We've also got a couple new low-cost sensors where we can't get the more expensive monitors in. So we've made improvements over the last 2 or 3 years for this issue specifically, and are working with Street Scene on their, you know, their plans for traffic management and the low traffic neighbourhoods. So we are working closely with them, and we're confident that the data that we have in our control is sufficient.
Thank you, Tom. Right, I've got, we're nearly at time, but in order of who's got questions, I'm going to take these all together. Councillor Rathbone, Councillor Adebayo, Councillor Turbot de Love, and Councillor Adams. So if you can try and keep it to 30 seconds each, and then we'll go to answers. Councillor Adams. Sorry, no, Councillor Rathbone. Councillor Rathbone.
That's fine. Okay. Are you explaining what you're doing with all this air quality, all the LTNs, all the other things that are going on, which are upsetting so many people in Hackney? Because the perception is that you're not. And I wondered, are you trying to explain? You have to keep explaining every single day, every week. This is what you do with communications. If you want to get the message across to people, why you're doing something. Are you explaining why? Again, to people, how are you responding? And well, like 30 seconds, but I have one or two other questions. I'd like to know what the progress is on finding a solution to home charging for electric cars across the pavement. That's something that lots of people ask me about, and it affects me as well. And also, I heard a little while ago in Tom's presentation that TfL and the council are not working together. Why not? And why is there? What is going to happen there? Surely you have to work together in this situation. And I'm noticing in Leabridge Road, in my ward, in Chatsworth Road, all that whole scheme, the council and TfL are not working together. And in fact, I'm very critical of TfL, who do not respond to anything as councillors that we write to them about, and certainly not to the public. So I think it's incumbent on the council to try and see if it can address that situation. Thank you.
Thank you, Councillor. Councillor Adebayo.
Thank you so much. And thank you, Sarah, for explaining to us about pushing traffic onto the major road. In my ward, Graham Road is a typical example of traffic being in that particular road, which some of the residents have complained about the impact of that on their health. I've got residents who mentioned the impact of the fumes on our children, asthma. So I'd like to know more, because some of the residents feel being left out, that the information are nowhere shared. And secondly, still on the fumes, is there any plan? We know summertime is barbecue time. So what is the council plan to work or to reduce the level of barbecue smoke?
Thank you, Councillor Adebayo. Councillor Turbot de Love.
Thank you, Chair. Just very briefly on the starborn areas, I would be good to hear what, especially the residents living in those starborn areas that you identify as a challenge on page 43. Are there any engagement with residents? Because we do see things online that, residents post about, pictures and videos of how concerned they are, especially about their health. Is the council communicating to them, telling them what's the process or what we're doing to improve air quality there? Thank you.
And Councillor Adams.
Thank you. Some of my questions have been asked by Councillor Rathbone. So I'll just go on a simple one, which is, how do Hackney results compare to our neighboring boroughs?
Oh, yes, good
Tom,
question.
do you want to lead the charge on that, and then I'll bring on Councillor Young to wrap matters up.
Yeah, so I'll rattle through the points I've got noted. Firstly, Councillor Rathbone's point on poor perception and what we're doing to explain. You're right, this is an area that is we have potential to improve upon, because we need to make sure that the positives, the positive data we are seeing, the improvements we're seeing, and the work that we're being done is being communicated and shared. And the other point to that, which I'm sure Councillor Young will focus on, is that does not always, the messages do not always land with everybody. And I'll leave that point there for Councillor Young to follow up on if she would like. there was the point on home charging, which again, I will leave for street scene colleagues. We appreciate EV charging is something that needs to be improved, but again, not for myself or Dave. Our work between, the communications between Transport for London and the council, we work with TfL's air quality team and on the matters that are of relevance for us as officers, for air quality officers. There are lines of communication between street scene colleagues and TfL, many lines of communication between them, I'm sure, but I can't comment further on that one. Regarding the question about plans for barbecues, we are aware that there are other sources of particles of smoke, etc. We will look into those sources in our new air quality action plan. What we can do on barbecue specifically is limited and governed by legislation. Again, I'm not going to elaborate on that further because that's not my area of expertise. That would be one for people who deal with enforcement, etc. But we are aware of that and what we can do on that. There was another point as well about Graham Road and traffic redistribution and how to get that information out. Again, as I'll refer back to my previous answer about the communications and what is being done. I think at the moment there is quite an acute problem that has arisen due to the roadworks there. That is temporary in nature and will be there will be changes in the next year or so where that acute issue may not be the case anymore. So all of the information that's being shared about the scheme, we will keep an eye on the data that's being collected in terms of air quality, the street scene team regarding traffic, and that will be shared as and when we have it. But at the moment, there's that temporary issue due to the roadworks. I think that's everything covered relating to
just the last one, Tom.
Engagement, and also Councillor Adams on comparing other boroughs.
Dave, do you want to pick that one up?
In terms of comparing how we compare with others, it's very much a kind of what you would expect for London, that the inner London boroughs will have similar air quality. And I think when we look at our concentrations, I think that we're very similar. And as you get out to sort of areas where you've got sort of less density of population and maybe less busy roads, then they're obviously going to have improved air quality. And I think we work with our neighbouring boroughs. I mentioned about the project where we developed AirAware, and there's various other projects where we're collaborating with the sort of inner London boroughs because we've got the same issues. So it's very similar that, we're not, I think that we are progressive in what we're doing, but in terms of the actual air quality concentrations, I think we're very similar. I just wanted to come in on a couple of points. Tom has answered the questions, but it's just a couple of examples. In terms of the comms, that AirAware project, part of that was actually working with residents and developing air quality champions. And we also then ran a sort of a longer term where we trained air quality champions who could then communicate to people within their communities. And then we ran an indoor air quality project where we recruited volunteers to monitor the indoor air quality and to give them some information about things they could do. So I think it's kind of, there are programs there to engage, but it's a really difficult one to do the comms because, trying to get people to engage, they might be experiencing the problems, but they don't necessarily sort of then respond when we're doing a project to engage them. And the other thing, just an example of where we do collaborate with TfL. Tom's just been working on a project to replace the enclosure at our Old Street monitoring station, and TfL, we share that monitoring station with them. So they work with us, they provided money to help us do that. So it was a really good collaboration, and I think we work well with TfL on the air quality side of things.
Thank you, Dave. And finally, if I go to Sarah, Councillor Young, for the final word.
I was going to start with sort of how do we work with TfL. We work incredibly closely with TfL. Street scene officers particularly, meet frequently and regularly with Transport for London. I meet with more senior Transport for London officers. I also meet with our liaison officer. I've also met with the Transport for London Commissioner recently, and we, not only do we work very closely with them, but all of our street related projects are funded by Transport for London under our local implementation plan. So we have to agree what we're going to do with TfL. They have to agree what they're going to fund. Often that will start with, we'll fund some research on this. You come back with us with the data to us. We'll then fund the next stage and the next stage and so on. So we're really collaborative with TfL, and we have to be because they're paying. That doesn't mean that their priorities are always the same as our priorities. So our top priority might be their 57th priority, for example. And so, often we are trying to press them to do things that they can see why we want them done, but they're not high enough up their list because they're looking at the whole of London and we're looking at Hackney. And that is a constant kind of push and pull between us and TfL. And we are seeing that on, on Homerton High Street, on the junction of Ponsford Street. We're seeing it at Manor House, various other places. So that's one thing. On comms, it's hard. Comms is really hard. The difference between what the evidence is, the very, very dry data, and what people understand to be their, people's lived experience, which is a real thing and evidence in itself, but also, what comes out in kind of social media can be poles apart. So, we can say, here's the data, here are the improvements to air quality in this area, but people will still tell you it's got worse. And we have to both listen to people's lived experience and look at what the, what the objective data says. I am meeting tomorrow morning with some residents of Graham Road to hear about their experience of how Graham Road's changed. Yes, we've got road works there, and so it's it's unusual at the moment, but I fully recognise that Graham Road is one of the roads where traffic has gone from those smaller roads. I've shared with the chair and with Jarlath the first major piece of research that was carried out looking at the relationship between deprivation and low traffic neighbourhoods. Since that research, there have also been updates, which I'm happy to share later on. But what's interesting is that in some areas of the country, the low traffic neighbourhoods were put in the most wealthy areas, and in Hackney's picked out as an example in this research of an area where that hasn't been the case, where actually it's been more deprived areas which have benefited. That's great. We're very pleased about that, but that doesn't mean that we're not continuing to look extremely carefully at where our changes are having an impact, and air quality is a huge part of that. Last point on Captain Turbot Delof's question about are we talking to residents? Because we've made so many changes to our streets, we have carried out a large number of long and detailed consultations. So we are talking to residents, not only are we talking to residents all the time in the way that we do as representatives, but we are formally talking to residents a great deal on these issues. So yes, a very small number of people have responded to the Air Quality Action Plan, but very large numbers of people respond when we turn up and do a stall about particular traffic changes or connecting Hoxton project or whatever. Lots of people talk to us formally and informally. And I think we've got a really strong sense of how residents feel, the things that they're concerned about, and and the things that they want. And sometimes those conflict. That is difficult, and communicating about them is difficult. My own view is we're heading in the right direction, but we've got a very long way to go.
Young, just because Graham Road is in Councillor Adebayo's ward, very quickly, Councillor Adebayo.
Just a quick one. You said you will be meeting the resident of Graham Road tomorrow. I will appreciate if you share the feedback with me. Thank you.
No,
I will. They are also hoping to bring a deputation.
I'm grateful. With that, thank you, everyone. Thank you, the officers, for coming to present on that. Guys, could we just have some quiet in the chamber, please? Thank you very much for everyone for your presentations on that, and Councillor Young for your work You've obviously got a collection of views there in terms of feeding back into what is the iterative process in terms of the action plan. And I think it's a good thing that this is a regular item on the agenda. So we'll get an update next year on where we are with what will be a new air quality action plan and the changes that have been made. So with that, I'll draw that item to a close and thank everybody. Members, can I just have the minutes agreed, please, the last meeting? And work plan is noted. And with that, I close the meeting and thank you, everybody.